Dr. Michael R. Bristow joins us from the CU Cardiovascular Institute at the University of Colorado Anschutz Medical Campus. He has authored over 400 peer-reviewed papers and chapters on heart failure and other cardiovascular diseases. He was instrumental in elucidating key molecular mechanisms underlying heart failure and the use of beta blockers for its treatment. He has identified and characterized numerous genetic polymorphisms that affect cardiovascular drug action, and he is currently engaged in the development of pharmacogenetically targeted cardiovascular drugs such as bucindolol. And in fact, his presentation today will be focusing on pharmacogenetic development and targeting of cardiovascular drugs. So we are pleased to bring to our stage today Dr. Michael Bristow. Thank you so much for being here.
Thank you. Thank you, everybody, for attending, and thanks for that very nice introduction, Karen. And so I'm colorblind, so the green is not a very good identifier here. Okay, so I got interested in pharmacogenetic drug development because of the difficulties we were having in delivering new heart failure drugs in terms of producing positive phase 3 trials. And so in so doing, sort of looking at the whole drug approval process and so on, it's clear that there's some general issues going on. One of which is, of course, there is this obsession at the FDA about safety, which began with Vioxx and continues to this day. There's a whole branch of the FDA that deals with safety. Fortunately, I think the pendulum has swung a little bit back in the right direction, and there is some better recognition now of a therapeutic index than there has been in recent years. Nevertheless, approvals, new drug approvals have been way down until this year, but most of the new drug approvals are not cardiovascular drugs. Within heart failure, we have our own set of difficulties, one of which I think is figuring out what an appropriate novel target would be to pursue beyond the success that we've had, for example, with neurohormonal inhibitors. That's a whole other topic that we're not going to get into. But the fact remains that the majority of phase 3 clinical trials, in fact 10 of the last 16 have failed, and so there's generally difficulty in once we get to phase 3 in producing a positive outcome and therefore a drug approval. So we're going to focus on what approaches could be taken to improve outcomes in phase 3 trials here. So fundamentally, our difficulty in heart failure and in general, I think all through cardiovascular drug development, is a low response rate. So these are just estimates of response rates that were put together several years ago in a paper ranging from what is a typical response rate in cancer, which is under 20%, all the way up to analgesia response rate. These are actually COX-2 inhibitors here, showing a 70 or 80% response rate. And for most cardiovascular indications, the response rate hangs out in the 20 to 30% range. So these are beta blocker response rates. Mild to moderate heart failure is better, 40% or so estimated response rate. You get to more advanced heart failure or something else we're interested in, which is prevention of atrial fibrillation, you're down in the 20 to 30% response rate range. It's very difficult in a placebo-controlled trial when you're dealing with these kinds of response rates to deliver a positive trial without thousands and thousands of patients in that trial and costs that run up to $100 million. So one clue as to where we should be going really, I think, occurred with the development of CRT, which I was involved with. So with CRT, you take a biomarker, essentially QRS lengthening, which is a surrogate marker for LV dysynchrony. You select those patients out, you treat them with something that resynchronizes contraction of the left ventricle, you get a good outcome. The response rate there is on the order of 30 to 40%, back towards where you'd like it to be. But if you actually took all the patients with heart failure, not just the 25% with QRS lengthening, your response rate would be estimated to be something like 10%. It would take tens of thousands of patients to deliver a trial positive in that case. So what you've done here is select out a subpopulation that is more responsive. Now, so you can do this not just with a surrogate marker of something that's important in terms of mechanism of action. You can actually do this pharmacogenetically, at least in theory. And so these are various ways you can use pharmacogenetics essentially to improve drug response. One is you can look at metabolism of drugs, and there are examples, of course, like with warfarin and so on, where you can use that information perhaps to deliver the drug more effectively. You can also have a biomarker of disease activity, and patients with higher levels of disease activity having more events and so forth basically lead to better powering of a trial, and so that will help you if you have such a marker of disease activity. But what we're really trying to do in our group is to identify genetic variation in a drug target, select patients that have a hyper-responsive genetic variant, match it up with a drug, and really go for a subpopulation that's going to have a better response based on the drug target's genetic variation. And if you can do that, and that's going to be the subject of the rest of the talk here, you also, in addition to improving efficacy, because you've improved the therapeutic index, safety's obviously going to be better as well. You're going to have a larger therapeutic index. So there are two approaches to doing this. One is sort of the big pharma, big science approach with GWAS, whole genome scanning, where you have no upfront hypothesis. You basically put a DNA bank into a phase 2 or phase 3 clinical trial. You generate terabytes of data. You find stuff that correlates with outcome, either efficacy or safety. You find a lot of stuff typically. The issue here is false discovery. You got to go do another study to test the hypothesis that your haplotype, for example, is something real. And usually you have no idea what the biologic basis for any of this is. The other approach is you go right to a drug target. You figure out the inherent genetic variation. You basically characterize the biology and the pharmacology of that. You find a drug. You basically test the specific hypothesis in phase 2 and phase 3 that genetic variant in the target leads to a better outcome with that specific drug. This is a more straightforward approach, and this is actually what our group does. Now, it turns out that if you do this, there are certain things you have to satisfy in terms of criteria for success, and these are just some of these. The first thing is you have to have a fairly common genetic variant. You're not trying to identify a mutation in less than 1% of the population and go after that. You're looking for common genetic variation, polymorphisms, and we would set the genotype prevalence in terms of being something of interest to be at the 5% level, which obviously creates enough of a market to basically recoup the investment on pharmacogenetic drug development. We think the genetic variant that you're after, that you identify, needs to be functionally important. It needs to be something that's not subtle. It needs to produce real differences functionally. By definition, it needs to reside in a disease-altering pathway. The drug target does, and the genetic variation. And then ideally, the drug that you identify would interact uniquely with that genetic variant. Other members of the class do not. That'll create exclusivity for your drug. And all these things have finite odds attached to them, and if you multiply the odds to satisfy them all, you come up with something that's less than a 0.1% chance of success, starting with any given single nucleotide polymorphism, for example, in the genome. And so this is why you haven't seen a lot of this done yet. This is actually quite difficult to do. So Karen mentioned the name of the drug that's sort of the lead product in this approach, and that's a drug called bucindolol, which has been around for a while, but it's a unique beta blocker. It has two mechanisms of action that are not shared with other members of the class. One is sympatholysis. This drug lowers norepinephrine, just like moxonidine and clonidine, for example, do. And the other unique property is that it's an inverse agonist in beta-1 389 arginine receptors, a genetic variant, meaning that it inactivates active state receptors, and other beta blockers don't do this. And so this is a cartoon of the adrenergic neuroeffector junction, big sympathetic neuron here, synthesizing and releasing norepinephrine. The target of all beta blockers is the cardiac beta-1 receptor on the cardiac myocyte. That beta-1 receptor comes in two important genetic variations at the amino acid 389 position, and arginine on the left, which is essentially the major genotype, if you will, or allele, if you will, and then a glycine version, humans being the only species with a glycine there, which is a loss of function, a genetic variant. The other mechanism of action is sympatholysis of this drug, and this occurs because of potent beta-2 antagonism. Beta-2 receptors facilitate norepinephrine release. When you block them, norepinephrine release goes down. If you don't have concomitant potent alpha-1 blockade, that norepinephrine effect will be lowering of norepinephrine. If you have potent alpha-1 blockade like carvedilol, that cancels out the norepinephrine lowering. And the regulation of norepinephrine release is regulated by prejunctional receptors, of which there are many. But it turns out that alpha-2C receptors are particularly important for that. And one of them, the alpha-2C receptor, alpha-2 receptors are important, tonic inhibitors, and one of them, the alpha-2C receptors, has an important genetic variant down here in the box. In the third intracytoplasmic loop, it's a 4-amino acid deletion, a 12 nucleotide deletion in the mRNA, and then leading to a 4-amino acid deletion right in the business end of this receptor, which basically creates dysfunction of norepinephrine release. And it turns out, interestingly, that this polymorphism is much more common in African Americans. The allele frequency is about 10 times higher in African Americans compared to non-African Americans. So there's a racial predilection to this. So these are data from the BEST trial, which in every patient had a norepinephrine measurement. And so the norepinephrine was measured at baseline, 3 months, and 12 months, and these are baseline and 3-month measurements on placebo and bisindelol by genotype, alpha-2C genotype. And you see if you have at least one copy of this 4-amino acid deletion, this deletion polymorphism, there's a much greater reduction of norepinephrine at 3 months in the bisindelol group compared to patients who had wild-type alpha-2C receptors. And it turns out that that big reduction in norepinephrine is associated with a trend for an increase in mortality, shown over here on the right. And this is the same kind of thing that happened with moxonidine. Too much norepinephrine lowering leads to a bad outcome in terms of increasing mortality. Whereas if you have the wild-type homozygote of the alpha-2C receptor, there's only mild norepinephrine lowering, and that's actually associated with a good outcome. So that's one of the interacting polymorphisms, therefore, with this drug. The other is with the business end, the beta-1 receptor on the cardiac myocyte, and I mentioned that's at position 389, and so there's this hyperactive, if you will, or hyperfunctioning receptor, the arginine version, and the loss of function version, a glycine there. And if there's an arginine at this position, meaning if you're homozygous ARG at that position, the receptors that you measure in the human heart, or if you make them recombinantly and express them in cells, have 4 times the signal transduction capacity, have more of them that are constitutively active, not requiring an agonist to lead to signal transduction, and a much higher affinity for norepinephrine. So this is just an example, therefore, of the much higher signal transduction capacity. So these are recombinant ARG versus GLI receptors. This experiment was done in Steve Liggett's lab. He's the guy that actually discovered these polymorphisms initially. And the first data point here on the left is in the absence of any beta blocker. It's the response in terms of cyclic AMP generation to 5 micromolar norepinephrine, and you can see the much higher response in the arginine version, roughly a 4 times greater increase in cyclic AMP. You give a beta blocker, here bisindelol, you inhibit both of them, but you're starting at a much higher level with the arginine, and that would lead you to believe that perhaps patients with that polymorphism would respond better to a beta blocker, in this case bisindelol. And it turns out they do respond better to bisindelol, but other beta blockers don't. So that pure competitive antagonism is not the explanation for this. So this is a measurement of norepinephrine affinity. This is agonist binding curves with norepinephrine. How you do this is you take membranes that are all beta-1 and ARG-ARG homozygous, and then do a competition curve with norepi. The curve on the left, without a high concentration of guanine nucleotide, is a biphasic curve. That high affinity displacement is high affinity norepinephrine binding or agonist binding. And over here is an estimate or an actual measurement of the percent of receptors that are in a high affinity agonist binding state for norepinephrine, averaging 42% for beta-1 ARG-ARG, and then less than 10% for any glycine, which is dominant negative here. And so much higher affinity for norepinephrine. If you average the affinity for norepinephrine across the low and high affinity binding sites, it's a difference of over 90-fold. Here's the other property. I'm going to cut right to the chase here in the interest of time. So bisindelol is an inverse agonist, meaning it produces a negative dose-response curve under certain conditions that bring that property out. That can be blocked with a neutral antagonist. The glycine version doesn't have that. These are isolated human heart preparations. These are force of contraction effects of the dose response to this drug. And for carvedilol and metoprolol, there's no negative displacement. These drugs are neutral antagonists. So that's the inverse agonism. So the basis for the differentiation, we believe, is twofold. It's, on the one hand, inverse agonism. It's not competitive antagonism. All beta blockers have equal affinity for both these receptors, including bucindolol. And then we believe norepinephrine lowering is very important because the ARG receptor has very high affinity for norepinephrine. It is the norepinephrine receptor in the human heart from the standpoint of beta receptors. And it turns out that if you have a glycine, a hypofunctioning receptor, and you drop norepinephrine down too much, that receptor can't support cardiac function. That's when you get a moxonidine type effect. You actually get a negative effect from norepinephrine lowering on the average with that receptor. So that leads to the differentiation of one genotype to another. And so what you end up with then is you have a population of a subpopulation of patients homozygous for beta-1 ARG. These are the people you want to treat. It doesn't matter how much norepinephrine lowering there is. They have a good outcome regardless. If you have a glycine at this position, it does matter about the norepinephrine lowering. And so the subset that's also alpha-2C deletion carrier that, remember, had the big norepinephrine lowering should not receive this drug. The other group of the wild type with mild norepinephrine lowering has sort of a standard beta blocker effect, and you can treat those patients. And so what you end up with then is sort of a 3 genotype setup. So the beta-1 ARG here for the primary endpoint in this sub-study at best basically is a hazard ratio of 0.57, a 43% reduction in mortality, statistically significant. Here's the glycine with the alpha-2C wild type, around a 20%, 24% reduction in mortality, not significant, but in the right direction. And then if you have the alpha-2C deletion and the beta-1 gly, you end up with this adverse effect, a trend towards an increase in mortality. Same thing happens with hospitalizations of all kinds, and if you look at the pharmacoeconomic impact of that, if you're beta-1 ARG, despite the fact that you're lowering mortality in patients who are living longer and at more risk for hospitalization, you're actually saving money because of the reduction in hospitalizations, something like $6,700 a patient. Over here on the right, you have this bad genotype, and you're losing money big time as you're basically tending to increase mortality. This goes to show you how you can take pharmacogenetic targeting and go right to the cost of medical care, essentially, in terms of differentiation of outcomes. So those were all heart failure endpoints we were talking about. Here's what happens with arrhythmia. So on the left is prevention of atrial fibrillation, which also follows the same genotype, but the difference is there's a lot more differentiation via beta-1 ARG versus gly. So there's a 70% or so reduction in atrial fibrillation, new onset in best in beta-1 ARG, virtually no effect in gly alpha-2C wild type, and again, a adverse trend for increasing atrial fibrillation in the unfavorable genotype. That's VTVF here on the right. Same sort of thing, except there's possibly a better effect in the gly alpha-2C wild type in that case. So in terms of prevention of atrial fibrillation, the only thing that counts basically is whether you're ARG or gly. So here's the time to event curves in beta-1 ARG, 74% reduction in atrial fibrillation, highly statistically significant. Any gly, no matter what the alpha-2C, there's essentially no effect. And there's a highly significant statistical test for interaction here. And so if you're going to go for approval for prevention of atrial fibrillation, which we're doing, you basically just identify patients who are beta-1 ARG and treat them. So a couple of clinical trials are in the planning stage. This is a big heart failure trial. FDA basically said, we like your data. We'd like to see some new data of some kind. So we offered them this heart failure trial. They basically said, okay, you don't have to show us all the data. Show us preliminary data after 2 years, if that's in the right direction, for bucindolol versus an active comparator that does not have this differentiation in the beta-1 ARG genotype. You basically will satisfy our request for additional data. And so here is the atrial fibrillation trial. This trial hopefully will be started later this year. It's the same idea, beta-1 ARG, active comparator, metoprolol. Primary endpoint is prevention of atrial fibrillation post-cardioversion there's a very high event rate post-cardioversion for recurrent atrial fib, 50 to 60% in 6 months, allowing you to do such a trial with a total N of 400, 200 in each group. So what are we trying to do here pharmacogenetically? We're basically trying to identify outliers in drug response. That's the whole goal of this. And in so doing, we will basically take the art of pharmacotherapy and convert it into more of a science, as was pointed out by Janet Woodcock and Larry Lesko a couple years ago in the New England Journal. So here are the collaborators. Steve Liggett and I have worked on these polymorphisms now for over 15 years. Dave Port in our group and Kika Sukharov have helped enormously, and there are a couple of companies involved in this development, and there they are. Thank you very much.
Thank you, Dr. Bristow. Ladies and gentlemen, we do have a few minutes here for a couple of questions for Dr. Bristow. If you raise your hand, I can get the microphone to you. Right here.
So, Mike, very intriguing data with the AFib. I was interested in the rationale for the EF less than 50 versus one all EFs, then maybe an EF less than 35, 40 of the stuff that we're comfortable with and that was an inclusion criteria for BEST.
Yeah, we were interested in getting into a patient population that wasn't just ultra-advanced heart failure and ultra-advanced LV dysfunction. So we want some amount of LV dysfunction. There has to be heart failure symptoms in the last 90 days, but not at the time of randomization. We're interested in getting to a patient population that's sort of beyond what's been standardly looked at in heart failure trials. That obviously has a couple of purposes. One is that it creates more of a market if you look at the numbers. That's one of the purposes. There are some regulatory issues why we did that as well that I won't get into, but there's a reason why we did it that way.
And so I guess the follow-on question would be, what about HFpEF and the ARG 389? Because that's a very highly prevalent AFib population as well.
Mm-hmm. Yeah, so I'm sorry, say that again, Doug?
Heart failure preserved EF.
Yeah, well, no, yeah, so we want to stay away from that. I'm the DSMB chairman of a big study, TopCat, in that population. That population has a lot of issues. It can be identified and studied and so forth. We don't have any preliminary data in that, so you don't ever want to go to phase 3 in a population you have absolutely no data in. That's the easy answer. And the other thing is that beta blockers have not shown any benefit in HFpEF. And there's been some pretty good whacks at it. So we think the average EF in this study is going to be in the 30-35% range, setting up these criteria. So.
We have a question here.
Hi, Dr. Bristow.
Yeah.
One of the other distinguishing factors you noted on that comparison between the different beta blockers was that the bucindolol had beta-3 agonistic properties.
Yeah. Uh-huh.
What role, if any, has beta-3 been implicated in this? Any polymorphisms identified or anything?
On the one hand, the answer would be not much. So I addressed this in a big review I published in Circ Research in October. It's probably a counter-regulatory receptor. It's GI coupled, and an agonist effect actually might be helpful in that regard. But there aren't enough beta-3 receptors in the heart and everything else, and the signal's so weak that I don't really think that does much. But what it is coupled to is nitric oxide generation, not just in the heart, but elsewhere. And so nebivolol has the same effect, and that's almost certainly a big part of its nitric oxide generation. Bucindolol has the same mechanism. That's part of its vasodilation. So on the one hand, not much in the heart, but on the other hand, if you believe in nitric oxide as beneficial, that would be one connection to the beta-3.